Well, hello everybody and welcome back to GUcast. Nice to be back, Renu.
Yeah, do you remember the studio, Declan? I feel like you've been travelling for ages.
I have been travelling for a few weeks, actually. And actually, I did record a podcast while I was away. I just haven't edited it down yet, so it might fall out of order. But I visited the Irish Society of Urology meeting back in my homeland a few weeks ago and made a bit of a podcast about Irish urology. It was a bit of fun.
Yeah, I remember some of the photos. I think there was a pint of Guinness in every one of them.
Did they all make it out, those photos? It was one photo,
Somehow.
5 angles, one
Yeah,
pint.
right, okay.
But, you know, when at an Irish urology meeting, have a pint of Guinness. That was the theme.
Fantastic.
But that
Well,
one
welcome back.
is coming. So, yes, that will drop because we have to edit them. It's a bit more laborious editing down those compared to these in the studio ones. So forgive me, but it'll come in maybe next week.
Yeah.
But yeah, back in the studio to talk about
great to be back,
hot paper again.
I think we have a
on
reputation
PSMA.
for talking about PSMA PET too much, and I don't think this episode's going to be any different.
Well, but in defense, usually it's because we're talking about prostate cancer.
That's
and,
true.
you know, we talk too much about prostate cancer, as I keep saying. But at least this time, although it's PSMA, we're not going to talk about prostate cancer.
That is true. That is true. It's going to be all about renal cancer, which is the new hype.
Yeah, there you go. Prostate specific membrane antigen brackets or renal cancer or other stuff. Close brackets.
Exactly.
So we've welcomed back two friends of the podcast to talk about this topic. It's Professor Michael Hofman, nuclear medicine physician here at Peter Mac. Michael, welcome back.
Pleasure to be here again. All my nuclear medicine colleagues have been talking about you, Declan, because apparently you were cited in Barcelona a few days ago at the European Association of Nuclear Medicine. And I think it's a big conference, 7,000 people. And I heard you were the only urologist there. Is that true?
Wow, it was fantastic to be there, I have to say, because it's a really big, good meeting, EANM, and I'm very aware that your community often show very, very big work at the EANM, and because, you know, my view is that some of the very, very best nuke med work in the world comes out of Europe, obviously you expect that meeting to carry, but it was a fantastic meeting, and I wasn't quite the only one. There were a few other urologists there, a few other nuclear urologists, as you'd say yourself, Michael, enthusiasts, and your good friend Stefano Fanti was the convener, but he put together a fantastic program, quite disruptive. He put a few good sessions on that were not in a normal sort of plenary layout. He had this arena planned kind of in the round with a lot of debates and challenge the expert sessions. Very, very enjoyable. But yeah, I really enjoyed it. It was fantastic.
Excellent.
And the setup looked amazing. I mean, all the audio visuals and the way the
cool.
arena was set up, it was just incredible.
It's the nuke med people. They like things just to look good.
It's no longer just sitting in a hall with your laptop out.
And also welcome back our colleague again at Peter Mac, Associate Professor Shankar Siva, radiation oncologist here at Peter Mac. Shankar, welcome back.
Thank you so much, Declan and Renu, for having me.
Good to see you.
It's exciting to have renal cell carcinoma talked about in such close proximity.
I know.
I thought this is a prostate podcast.
Yeah.
Oh, you guys are just on recently talking about renal cell cancer.
He's right, but it went down really well. We always get good feedback when we don't talk about prostate cancer. So there's
true.
a lesson there. So that's our kind of ambition now next year is much less prostate, much more other stuff.
Yeah, absolutely. And we're going to welcome back another great friend of the podcast, someone who's got a lot of interest in this area, and we're seeing some great stuff from her. So this is Dr. Rana McKay. Sorry, did I pronounce that right, Rana?
Yeah,
Despite my
right.
practice.
Even though it's McKay is actually Scottish. It should be Mackay, but it actually evolved into McKay, right? That's I'm not Scottish at all, but from my husband's background, you know.
Well, excellent. Well, Rain is a GU medical oncologist from the University of California in San Diego, UCSD. So welcome back, Raina.
And it was partly because her episode with Shankar a few weeks ago was so
Was so
popular when
good,
we
yeah.
talked about the role of radiation for renal cancer. We got really, really good feedback about that. So well done to both of you for putting on some great discussion. And it's kind of a flow on from that because although this topic is this program's labeled PSMA, we're not going to talk about renal cancer because one of the odd things, Michael, we found over the past few years here at Peter Mac as we developed a lot of experience with PSMA PET CT. For prostate cancer is suddenly we're beginning to see kidney cancers light up and metastases light up. And before we talk about Shankar's paper published in European Urology a couple of weeks ago, do you want to just remind us a bit about that journey over the past 8 or 9 years and how we started looking at renal cancer using PSMA PET CT?
Sure. So I think here we did our first PSMA PET CT in 2014, so 8 years ago or so. Now, obviously, the Europeans did it even a few years before us, and this is a well-known cell surface marker on prostate cancer. And it's also expressed in neovasculature, which means it shows up in a whole range of tumours. I mean, we know that tumours need to grow, so you need lots of neovasculature, and PSMA is expressed there as well. So we do see uptake in a whole range of tumours, but it's usually really low grade. But I don't know, somehow people stumbled across renal cell having really high uptake on a PSMA PET scan, really striking, sometimes not that different than what you see in prostate cancer. So perhaps we need to rename it and not call it PSMA. What would you like to call it, Renu?
Well, it's definitely not PMSA.
Definitely not PMSA, like many people say. Do you want to rename it, Shankar? Do you have a better name?
PRMSA?
Oh, PRSMA.
MSA. SMA. We can just keep adding letters
the
and we
S is the
discover
problem.
more.
It's not specific for stuff. It's
But I
just,
have been thinking about this, because if we take that approach, what do we do with things like BRCA1 and BRCA2, BRAC1? That's a risk factor for prostate cancer, but it's B's for breast. Nobody renamed it.
I think you think too much, Michael.
Yeah, I think he does.
No, that's a very interesting question. I think there was actually a paper about renaming BRCA1 and BRCA2 syndromes to King's syndrome, right? Based off of the person who actually identified the gene and the linkage. And it's actually a bit controversial because I think it sends the wrong message to the community about the importance of BRCA1 and BRCA2 for not just prostate, but also pancreatic cancer. So
Yeah,
Absolutely.
I do think we need to think about nomenclature. Nomenclature matters.
it really
There we
does.
go.
Well, maybe coming out of this, we're going to write a commentary about how we should rename the PSMA. Here's the authorship pool, or if anyone else
Absolutely,
out there wants to join us, you're very welcome to
give
do
us some
so.
suggestions.
But yeah, that's what's happened. So lots of PET scans getting done for prostate. And I remember in the PRO-PSMA trial, which was a prospective study, one of my patients did have a renal cancer in there as well as a prostate cancer. And I recall that patient, we ended up doing his kidney cancer first, then his prostate cancer. And it was really, well described. But then they were incidental. So, but flowing on from that, Shankar, I recall with 4 or 5 years ago at the MDT meeting at the tumor board, people were saying, well, let's do a PSMA PET CT here to look for, is this a renal metastasis or not in patients with known renal cancer? How did we end up going from finding these things incidentally into all of a sudden we're doing dedicated PSMA PET CTs here for this?
It's actually very interesting. It's longer than your memory actually serves. So the initial PET scans for PSMA were in 2014, 2015 for RCC. And I think that came about from a conversation Michael and I had about RCC. We'd seen a paper which had shown some increased expression, I think from a German authorship group. And that took us into actually trying this in the renal cell space.
There's a couple of key differences, though, between prostate and renal cell cancer, isn't it? I mean, you touched on one, Michael, is that the PSMA is actually expressed in the neovasculature as opposed to the tumour cell itself. And secondly, we're not using it so much to sort of primarily diagnose renal cell cancer because there's physiological uptake of PSMA in a normal kidney anyway. But it's more to look at sites of metastasis. Is that right, Shankar?
Yeah, absolutely. And this might be a good segue to talk about the paper if you'd like. So this is a paper we just published in European Urology Open Science. Christian Udovic is the primary author, who's just a newly minted radiation oncologist at Peter Mac, just passed his exams. And this study looked at the PSMA series at Peter Mac from 2014 to 2020. So we actually did over 3,000 PSMA PET scans in that time, of which this was looking at patients that we were looking for RCC as a smaller cohort, of which there were 80 patients that were done for RCC. And of that, there were 61 that we were doing for the indication that we were probably thinking was the best indication, which is looking for recurrent metastatic disease or for screening for oligometastatic disease. So that cohort of 61 patients, we actually had matched 40 patients that also had FDG PET, so it gave us a good comparison of not quite a standard, but a different type of PET tracer as well. And interestingly, from the PSMA PET perspective, it was more sensitive than CT, about 88% sensitive than both CT and PET. And the SUV means and maxes were much higher. So SUV max was 15 versus for FDG PET, which is only 8. We actually classified it based on what the impact was because we wanted to see if it changed management, and that was based on prior publications where we classified into high impact, medium impact, low impact. In this situation, we classified high impact as either changing the site of treatment, changing the modality, for example, from systemic therapy to radiation or surgery to another modality, for example, and also the intent from either curative or palliative. And it was roughly 50% of patients had a high impact scan based on the PSMA PET, so it was very useful.
Wow.
Yeah.
if this was a prostate talk, we'd be saying, how did it compare to the bone scans?
And we'd
Well,
also,
I think that this is, highly relevant, right? Because I think in RCC, metastasis directed therapy is something that we've been doing for a long, long time, and implementing SBRT for oligometastatic disease, or even metastasectomy for oligometastatic disease, and then surveilling patients has actually been a standard of care, and remains a standard of care in the modern era now. So I do think that there is something to be said about detecting early disease onset with, integration of metastasis directed therapy.
yeah, I totally agree with you. But you still wonder why a PSMA PET CT. That's what I always had wondered. And well done to you and your team for putting that together. So at least we have something to point towards, albeit retrospective and very selected and so on. What's the reaction been to it? Are people thinking, okay, yeah, we need to do some nice prospective work on this, or nah, we should just stick with conventional imaging. That's how we normally stage low volume renal cancer.
Yeah, it's really hard to gauge, I guess, the international kind of practice, because PSMA, as you know, is not as readily available potentially as ubiquitously as we do have in Australia. Certainly locally, I've noticed in other community clinics or MDMs that we go to as well, there are people suggesting very commonly we use PSMA PET in the context of RCC. So I don't think it's necessarily PMAC-centric. It's definitely disseminated into the Australian community. Be interested to know what's happening in the US.
Yeah, I think for the US data, I think we're just beginning to kind of roll out PSMA imaging more broadly for patients with, prostate cancer, but just given how common prostate cancer is, and actually kidney cancer is a top 10 malignancy in both men and women, we're seeing patients who are, have prostate cancer who also have concurrent renal tumors. And I think this is sort of beginning to unravel a series of questions about, well, is there a role for PSMA imaging for detection, for metastasis, for surveillance, and potentially therapeutic intent down the road? I mean, we don't have that data as of yet, but I think it's just beginning to open up a big can of worms of questions around diagnostics and therapeutics.
Wow.
Is that where we're going to get, do you think? Are we seriously going to be thinking about theranostics for this? Now, Rana, you've got some interest in studying the biology of PSMA, fall H1 expression in renal cancer. Do you want to tell us a little bit about that?
Oh, yeah. So we've actually partnered with, a commercial database of patients with, whole exome, whole transcriptome, or panel testing, about 1,700 patients with renal cell carcinoma who have been genomically profiled, and looking at basically full H1 expression across sites of metastases, across histology, and actually correlating expression with angiogenic signatures and also outcomes to therapy. So, submitted an abstract for GU ASCO, kind of highlighting this full story. And really what we've demonstrated is that clear cell RCC tumors tend to have much higher expression compared to non-clear cells. So as we think about rolling out a diagnostic or even therapeutic, I think really this seems to be specific to renal cell carcinoma. It also does seem that the sites of metastasis have higher expression than the primary renal tumor. So I think this gets a little bit at what Shankar was saying about using this modality for metastatic detection rather than necessarily like primary detection. And interestingly enough, it does seem that based on the site of MET, the expression is variable. So expression seems to be statistically significantly much lower in lymph nodes, while not numerically significantly higher in bones, but it does seem to be a little bit higher in bones, but it's not kind of a statistical significance when you compare it to the primary. Another thing that we looked at was sort of the angiogenic gene signatures. So there's been a lot of work done in kidney cancer looking at RNA-seq signatures potentially being predictive of response to VEGF-targeted therapy or even IO therapy. This is data from the Emotion 150 and 151 data sets looking at atezolizumab and bevacizumab in advanced RCC. And there was, in the 151 paper, looking at 7 different clusters, and 2 clusters were really, angiogenic high. And there was a correlation, of increased full H1 expression in the angiogenic high signatures. And in those signature scores, full H1 was not used as one of the genes that was determining, high expression or low expression of those scores. I think the last thing is like correlating with outcomes. And it did seem that patients who were on VEGF TKI based therapy and had high FOLH1 expression seemed to have, better outcomes compared to patients who had low FOLH1 expression. So we're just beginning to sort of unravel the underlying biology around this, but it does open up the door for, is there a role for a potential therapeutic here? And while we know that we're targeting the neovasculature, a lot of the therapies in kidney cancer are in fact targeting the neovasculature with regards to VEGF inhibition. In RCC, the tumors get necrotic, they're become avascular, or that's the intent of the therapy, if you will. So, I think it does open up the door. And I think with regards to radioligand therapy and RCC, we actually have a study of radium-223 plus cabozantinib and RCC looking at specifically patients who have bone metastases. Is there an effect of radioligand therapy there? While a lot of, I think the historic teaching has been that these tumors tend to be more lytic on imaging, but in reality, actually, they have both increased osteoblastic and osteoclast activation. And then also there's girentuximab, which is a CA9 targeting radioligand therapy that is being tested in RCC in very early stages.
Wow. That is so fascinating, and what a great summary of it too.
You might definitely have to rename PSMA if it does show utility.
So it's interesting, isn't it? Because for the general audience out there, FOLH is folate hydrolase, and it's an enzyme, isn't it? Right, and it's in PSMA, the molecule.
It is PSMA. So PSMA is FOLH1.
Right.
And I have a Google Scholar alert on PSMA. So any new papers that have PSMA in it pop up on the weekly Google summary. And even me, as a very PSMA avid clinician, struggles to keep up on the amount of literature coming out on PSMA at the moment. And it is really described in all malignancies and mainly around neovasculature. But prostate's really the only one that has cell surface tumour receptor expression. So it's very different in prostate cancer than these other tumours. And,
salivary gland tumors, right?
Well, it's even salivary gland tumours, whether it's cell surface specific is debatable.
Interesting.
So prostate is a bit of a standout, and the sort of SUV, standardised uptake values, we see on a PSMA PET in prostate cancer generally aren't seen in most other malignancies. So we can see SUVs of 100, 200. My record is 340. This is super intense uptake. You just don't see that in other tumours. Most tumours that have PSMA in neovasculature have really low uptake. PSMA is less than 5. In fact, we've done a paper on incidental PSMA avid tumours found on PSMA PET scans, and you find that in every tumour, from melanoma to, you can name every tumour, and you'll get low intensity uptake. But that's really easily differentiatable because it's got lower uptake. But renal is a bit of a standout because you do see pretty intense uptake in renal. You can get SUVs of 20 or 30 in renal cell. But it is important to remember that a PET scan's a dynamic functional scan, and what you're seeing is uptake at a particular point in time. So you inject the tracer and you image at 60 minutes. So you are seeing receptor binding of the small molecule at 60 minutes, which is a very early time point. But for therapy, you need to know, does it stick there at 24 hours, at 48 hours? Because lutetium-177 has a 7-day half-life. So if it binds and you see it on a scan at 60 minutes, it could disappear by 4 hours. You can't see that on a PET scan because the positron emitters have short half-lives. So you can image them within sort of 1 to 2 hours, but you can't image them out to 24 hours easily. You can if you use a long half-life tracer. So here is a problem because we do know that it washes out of neovasculature, whereas it sticks and is actually internalized when it's cell surface binding. So there are some fundamental differences here, and there's also some publication bias because, lutetium PSMA therapy evolved in Germany, really off-trial, compassionate access treatment. So how many patients in Germany with metastatic renal cell carcinoma have had lutetium PSMA treatment? And the answer is, in the literature, 0. I've done a search for lutetium PSMA in the literature and you can't find a single case report. But if you travel to Germany and go deep into the bellies of the nuclear medicine departments, you'll see that they have treated patients with lutetium PSMA, but they haven't published their results. Why?
Wow.
Because I think anecdotally
It doesn't work.
it doesn't work. When they did the pictures at 24 hours, They didn't see any tumour uptake. It had all disappeared because it washes out. And then they felt a little bit silly having done it, so they didn't publish the results. So I think we do need some prospective data, but there are some anecdotes that are not particularly exciting.
Maybe just using that particular radioligand therapy. Do you think if you use something else different, or is it going to be the same problem because it's not cell surface, it's neovasculature?
It could be a fundamental problem of using a radioligand approach, but there are always ways to overcome this. So you could use a short half-life alpha emitter. Some alpha emitters have a 60-minute half-life. Then you would probably get very high salivary gland uptake, so you would have some high off-target effects, maybe very high kidney uptake. So there are some fundamental problems here, but it is worth studying. Don't get me wrong. I'd love to see some prospective studies doing this properly. And it would be probably good if some of the people doing this and failing publish their negative results, even if it's a single case study. This is a bias with the compassionate access type approach. You tend to rush out and publish the first lutetium PSMA therapy when you have a spectacular response, and then if you have a spectacular failure, you just sort of bury it and stop doing it.
Or maybe the girentuximab that you mentioned, the Zircon study, which we're running here as well. Rana, that may be a different approach, the attaching CA9 and all that. But it's interesting, isn't it? So I think, what's your take on it then, Shankar? Forgetting about the theranostic stuff for a second, what about just the clinical utility of PSMA PET CT? What does this European Urology Open Science paper tell us? Is it just the opening the door to we should do a prospective study evaluating the role of this in the metastatic setting, for example, or are you still using it within routine clinical practice? I know you've got a prospective registry going.
Yeah, so we do. So we just opened a prospective registry for use of PSMA for RCC, and that's something that is currently open at Peter Mac. But it'd be nice to be able to open up at other centres in Australia. We're eyeing off a couple of Brisbane sites. But yeah, I was just in clinic this morning and I ordered 2 PSMA PETs for patients with RCC that I was thinking about metachronous or recurrence, and one with a recurrence in the renal bed. And it's really my standard reflex. If I'm thinking about metastasis-directed therapy, I want to make sure that I don't have occult sites of other metastatic disease that would mean that local therapy would be futile. So I think it really does help me select the best patients for treatment.
Yeah, I think of PET scanning a little bit like an extension of clinical examination. I mean, we can ask for prospective randomised data of PSMA and RCC, but I actually don't think that makes much sense. If you see 2 metastases and you're going to give SABR to 2 sites because you believe, based on imaging, that there's 2 sites of disease, well, you want the best imaging possible, because if there is indeed 10 sites, what you are about to do based on CT, bone scan or MR, it makes no sense. I could ask the same question and say, show me the prospective data for CT. Show me the prospective data for MR. It doesn't exist. So I think the prospective studies need to be centred around the treatment, i.e. SABR. Does SABR work in this setting? Show me the randomised prospective data. And then as you do those prospective studies of an intervention, you ought to choose the most appropriate diagnostic. And that's probably where PSMA PET fits in, because it is a new, let's say, call it standard of care for at least clear cell renal cell carcinoma. We know it's better than CT bone scanning. And then we shouldn't forget the other component of this publication, which is the FDG. I don't know, would you like to tell us about the role of FDG, and when do you order a PSMA PET and when do you order an FDG PET? Or do you just say, hey, I'm at Peter Mac, I'll do both?
That's a good question. I think, FDG, we have very specific funding indications that are specific to solitary pulmonary nodules that may be of use when we're indeterminate for FDG PET scans. So that's helpful. That's one criteria for selecting locally. But often the FDG PET avid areas can often be a marker of dedifferentiated disease and more aggressive biology. I don't think it's very helpful, potentially, FDG, for that indolent patient who has a long disease-free interval and a slowly growing metastasis, for example. I think that's probably better to be able to screen for occult disease using PSMA. But if someone's got rapidly progressing disease or some nasty-looking disease that may need some intervention in a short post-haste, then I think that's probably a good role for FDG.
Did you get any indication, Shankar, from your data set, sort of a correlation between PSMA PET uptake and the histology? Because from what Raina's saying, it's the clear cell cancers that really express FOLH.
Yeah, so that we did actually look, so this series had the majority of clear cell, 89% had clear cell, but there was a smaller minority that didn't have clear cell. And interestingly, some of them, about half actually had uptake. So They were definitely lower intensity than the clear cell. Clear cell had a average SUV max of 15, but just quickly check the interquartile range actually got up to 28, so quite hot. 25% of patients had more than 28 SUV max. But the non-clear cell groups were lower than that, but still about half were uptake. So the classical kind of understanding is clear cells are the most useful kind of histology to be testing PSMA in the RCC setting, and the others may not have as much uptake, and that's probably what we're seeing, but it's not completely useless.
So is it going to come full circle and he'll be finding incidental prostate cancers on these renal cancer scans? Renew, what do you mean?
Maybe. That's how prostate cancer is going to be diagnosed in the future.
Incidental PET scanning.
Raina, so would you, for high-risk renal cancers, we don't really have any good evidence for adjuvant therapies. So would you recommend looking for FOLH expression routinely in these patients so that we can then surveil them using PSMA PET scans?
I don't think that we're there yet. I think the adjuvant role the adjuvant setting is definitely evolving in RCC. We've recently seen it this past ESMO, 3 negative adjuvant perioperative studies report out. This is on the heels of the Keynote 564 data getting presented last year at ASCO, and that study demonstrating that pembrolizumab improved outcomes for patients. So I think we're still kind of scratching our heads a little bit in the adjuvant setting, exactly what to do. I think it's interesting as we're talking about treatments for these patients, and actually building off of the podcast we previously taped about the role of SBRT, it just actually got me thinking about, is beta emission enough to treat a RCC tumor, where we were talking about, SBRT was a novel modality to be able to actually introduce high enough radiation to actually cause an effect. So I don't know the answer to that. I'm not a radiation oncologist, Shankar. I don't know if that's something that you've thought about regarding, alpha emission versus beta emission, and whether that's even enough. Should the molecule even stick within the tumor microenvironment?
Yeah, it's a tough one. Michael, I might pass to you.
We have to be careful and they pass to us.
No, I've got to be careful. Look, I think if it sticks, that's question one. And because the PSMA PET scans are deceptive, you kind of see high uptake. It looks not too different than a prostate. So you go, well, it works in prostate. Let's just do it in RCC. But if it doesn't stick, it's not going to work, because there is no magic to our treatments. If it doesn't stick, your dosimetry will be very, very low. I sadly suspect that's what we're going to see in this setting of neovasculature uptake. But someone does need to look at it, because I might be wrong and we may be missing something big. Now, you could just test this with a long half-life positronometer. You could do a zirconium-89 PET at 24 hours and answer the question, similar to zirconium-89 girentuximab, a long half-life tracer where you can actually see it at 24 hours. So you could do an imaging study rather than a therapy study to answer this question definitively. You could even use a SPECT, old-fashioned SPECT isotope like indium-111, and image at 24 hours. So it's really interesting. I think if you get high doses, beta will be fine. It's no magic. You can get super high doses. In prostate cancer, we can get doses of up to sort of 180 gray with a beta emitter, extraordinary doses in the upper extreme. But Raina, I'm interested in since you've got interest in cell surface markers and prognosis, what other cell surface markers are very good in renal cell carcinoma? I was just thinking in my head about Ki-67 as a proliferative marker. Is that something that's just better than looking at neovasculature? You want to know how quickly it's multiplying?
Yeah, I think we don't really use Ki-67 too much, I think, in RCC like in other tumors, but I think the other cell surface markers, CA9, CA12, those tend to be more specific to RCC. I think RCC is a little bit unique. It's not really a epithelial tumor that largely expresses EpCAM. I think this has come up with, CTC markers, for example, for CTC capture, that you can't just use sort of like an EpCAM-based strategy for capture. So I think, CA9, CA12 are ones that can be looked at.
It's a good thing about external beam, isn't it, Michael? It's very sticky.
It's very sticky. You know exactly what you're delivering where. You just can't control the crossfire to those normal tissues.
We just need a PET scan to tell us where to fire, right?
You can, and you can combine those with the PET Linacs.
That's true.
So that's another role where we have been looking at PSMA PET in particular is in a PET Linac. Do you want to explain how that works, Shankar?
Yeah.
So it's a very interesting new technology, but there is a hybrid PET linear accelerator that's currently commercially available, and it's an interesting piece of tech because it uses the tracer to be able to help direct the area to treat, so you actually truly see what you treat, but it's external beam, so we get really sticky doses and very high stereotactic kind of doses.
What's the buzzword for that?
BGRT, biology-guided radiotherapy.
Wow.
Oh, there you go.
That's
Learn
awesome.
something new.
Shankar, you guys wrote a really nice article in Nature Reviews Urology. You know, it's sort of a summary of the uses of PSMA PET beyond prostate cancer. And, you know, it's been studied in other things like urothelial as well, but pretty disappointing in that arena, isn't it?
Yeah, I think, and it goes back to what Michael was saying, there's certain cancers that do have high levels of uptake, which can make it potentially useful. In urothelial, it's been disappointing. Some of the sense has to do with that renal uptake and then excretion through the urinary tract. Therefore, trying to look for lesions within the bladder is almost impossible. And looking for metastatic lesions that just doesn't have enough uptake. So I think there are certain indications like kidney cancer, which are great. In fact, lung cancers do take up PSMA as well. So we've often been confused. Once in a while, we might see a PSMA-avid lung lesion in the context of a prostate cancer patient, and then it ends up being a primary non-small cell lung cancer. So these kind of things do turn up, and I guess it's trying to separate the zebras from the horses.
Yeah.
Fantastic.
Great 2 papers. We'll post links out on
So
our...
what's the conclusion for the listeners out there? If you're in a tumour board tomorrow and some person 3 years after a nephrectomy has a small nodule, and if you're in the tumour board, you could shout up, maybe you should have a PSMA PET CT.
Yeah.
Or would they get shouted down? Raina, what would happen if you said
Let's go
that
around the room.
in San Diego?
I don't know if I could ever get it covered. And that's sort of the world that we live in here in the US. But I think, you know, at the end of the day, I think sometimes it's like no meat, no treat. You know, ultimately, we may end up getting a biopsy, I think, at the present time. But it's very provocative.
Should be done in a study, I suppose. That's always a good answer. But anyway, nice work, Shankar. So you're studying. And another question I forgot to ask you was: is this all gallium-68 or some DCF-PYL? Because we tend to use both here quite a lot. Or does it matter?
No, correct. It's both traces, and I don't think it makes a huge amount of difference.
Yeah.
Yep, they're both very good.
Right.
All right.
Very good. There you
was
go,
really
folks.
good. I learned a lot today.
Renal cancer episode with Raina and Shankar and special guest Michael. I think, it's great to talk about renal cancer. We should do it a lot more, shouldn't we?
Yeah, yeah.
We
We're hearing a lot more from these two.
We had a request to
Michael.
talk about stones.
Oh,
I'm not sure
no.
if that is
Please don't invite me.
because urologists love stones, you know.
Renal stones with Michael
everybody loves
Hofman.
I think we need a
stones.
radioactive trace that binds to calcium.
With a lot of stickiness.
Yeah, anyway, it's just out there. I'm just saying, just kind of forewarning people that a few GU cast regulars have said, you should do something on stones, you know, suggested by a stone surgeon, and she was very keen to come on. So, stones could be coming soon. GU cast now doing stones. Next thing, BPH and testicular pain. Yeah. Anyway.
All right.
That's great. That's all we have time for. Raina, thanks so much for joining us again.
Thank you.
And you guys are going to catch up soon at PCF Retreat
At
next
PCF
week.
Retreat next week?
PCF Retreat.
Yeah.
Renal will be coming over to see you in California. Thanks very much, Michael and Shankar, and congrats again on this nice paper. Really nice work.
Yeah.
Thank you very much.
That's all we have time for here. We'll be back very soon again. We might drop in the Irish one if I get a chance to edit it this weekend, or if I get my son to edit it with me this weekend, and that will be fun, I guarantee. Take care.